Welcome back to Health Matters. I'm Chris Moore, Dean of Sargent College. I'm very pleased to introduce our next presentation, How Technology and Big Data Are Changing Rehabilitation. This presentation will be provided by Dr. Swathi Kiran. Dr. Kiran is a familiar name, a very familiar name to those of us in speech-language pathology. Professor Kiran is an ASHA Fellow and a leading authority in aphasia. She serves as Program Director for the Speech Language Hearing Sciences PhD program and is the Director of the Aphasia Research Laboratory and Research Director of the Aphasia Resource Center. Dr. Kiran is the co-founder and scientific advisor for Constant Therapy, an organization that provides personalized therapy tools for people with aphasia, traumatic brain injury, stroke, and learning disabilities. Welcome, Dr. Kiran.
Good afternoon. I'm very excited to be here and talk to you about how technology and big data are changing rehabilitation. Let's look into the future a little bit. This is John. He's about 48 years old, and he has just had a stroke. He's admitted to a hospital, and after about 2 weeks of intensive care, is now released into a speech and hearing clinic or a lab like the one at Boston University or a rehabilitation hospital. At this place, he gets a complete neural profile done, which is brain scans, a complete neural and language and cognitive profile done to understand what he can communicate and what he has trouble with, as well as a social functional profile. So it turns out that he has a PhD in psychology and he's married and he has 2 children. All this information is then fed into a computer model that predicts the prognosis for John and his recovery trajectory over time. Based on that information, he's going to be advised to either attend intensive aphasia therapy as well as some individual one-on-one therapy, or get some individual therapy and participate in some social groups, or he may be asked to participate in social groups and get some vocational training. Well, this is in the future. We're not there yet, but I think we are ready to start addressing these kinds of questions because all the basic elements of what we would like to do to predict treatment recovery are in place. First, we would like to understand what is the effect of brain damage on the brain itself. And so these are getting neural markers on the brain. We also like to understand what is the effect of brain damage on communication? What can the patient communicate and what is he having trouble with? We're making gains there as well. And then we would like to understand what are the average gains, what are the population gains that patients make when they receive treatment. And all this information is then utilized in a very complex algorithmic fashion to then predict each individual's patient's treatment outcomes. In terms of neural markers, there have been tremendous advances in technology over the last 10 years where we can now understand what the effect of brain damage is on specific parts of the brain. We can also understand how the tracks in the white matter of the brain change as a function of the damage to the brain regions. We can also understand which parts of the brain are active when there's damage to other parts of the brain. And we can understand how these regions interact as a network. We can also understand how the brain functions when it's doing a language task relative to when it's at rest. And all this information is now coming out to be what we're calling neural biomarkers. So we're getting there. When we look at language markers, work done in my lab as well as other labs across the country have found what the effect of brain damage is on language processing. But we've also been looking at what the effect of brain damage is on attention and problem solving and how they interact with language processing. We've also been looking at how the brain damage affects people's ability to control irrelevant information, as well as how it controls, how they can control their executive function skills and how all these influence language processing in general. So we have a very good idea of how the brain damage affects people's ability to communicate and what are the factors that affect each individual's ability as well. Now, when it comes to treatment gains, so what is the treatment that works for patients, we haven't made that much progress. There have been studies that have looked at patients' improvement on specific types of impairments, but sadly, these are studies on very small populations. The few studies that have been done in larger populations haven't been as robust. So it's really unknown which treatments work for what kinds of patients. And until we answer that question, what works for the patient, it's hard to standardize and personalize the intervention that each patient needs. You would think this is a little strange, given that if you're diagnosed with asthma, you know exactly what medication you're going to get. But in rehabilitation, we're not there yet. And this is the big problem that we are trying to solve. Now, it turns out that the current state of rehabilitation for communication deficits in the field of speech-language pathology is pretty archaic. Clinicians typically download a bunch of flashcards or cut out papers and pictures and use it in their therapy settings, or search through workbooks of pictures that they would use for their patients. And it's really up to the clinician to keep track of what she's working on with the patient. Now, compare that to everything else that you do in your world. You go to the website and you click on your shoe size and you click on the heel size and you click on the color, and you have your personalized shoe delivered to your home. Likewise, you go to a website and you filter all your preferences about which class you want to fly and how long you want to fly, and you have your personalized ticket. That's the world of technology, and that hasn't yet come all the way to rehabilitation, although it's inching there slowly. There have been several studies in the recent years that have looked at the effectiveness of computer brain training programs on brain damage, and the evidence is promising, although the numbers are again small. There have also been computerized rehabilitation programs such as MultiQ and MozTalk, which are designed specifically for patients, and those have also had some promising results. I'm going to tell you about one study that we have done that has tried to examine whether we can standardize the delivery of therapy using an iPad, and this is a paper that came out a few months ago. In this study, we had 51 patients who were varied in their aphasia quotient as well as the cognitive linguistic severity. And these patients were either assigned to an experimental group or a control group. The experimental patients came once a week and worked with a clinician and on the iPad, and then took the iPad home for the rest of the week and were asked to practice as often as they wanted. The control patients only came in once a week and worked with the clinician, so the experimental patients got homework as well. And what we tried to do in this study was to deliver therapy in a standard way, but at the same time try to address each patient's impairment as much as possible. So at an initial baseline session, the clinician would try to understand what was the patient's specific deficit, then only assign the treatment task that would work for that patient. And once that was done, she would assign the homework, and the patient would go back home and practice as often and as much as they wanted. As they were doing the practice at home, the clinician could remote log in to the system and check and see how the patient was progressing and change the treatment protocol if required. What we found was that, of course, patients, the experimental and the control patients, improved as a function of the therapy they got. Experimental patients improved more than control patients. But what was really interesting about this study was when we tried to look at what the initial starting point was for these patients, and when we tried to look at what their severity of deficit was, we found that there were specific treatments that work for specific patients. So there were certain therapy tasks that worked for patients who were far more severe, and they were really improving on those tasks, whereas there were other therapy tasks that worked for patients who were less severe. So this was the first time we were able to match the patient's level of deficit with the exact treatment that worked for that patient. These patients also showed, the experimental patients also showed more gains on the standardized test than controls did. And the other thing we found was patients with lower initial scores showed more improvements than the patients with higher initial scores. That's hope for patients who are very severe and have given up therapy. This study and all the other studies that have been published in this field are very small in number. There are very few patients who've been studied in these sets of studies. And these numbers pale in comparison to the kind of data we could be collecting with technological advances. So in the Constant Therapy app, there's up to 500 and thousands of patients' data that have been collected across different tasks. And this allows us now to start looking at population-based analyses of what treatments work. So in this slide, you can see that there are all these different bubbles, and each of these bubbles size indicates how many patients have received the therapy and improved. And I've picked the example of sound identification because this is a very fundamental phonological processing therapy task. And 335 patients have improved on this task. And the average gain that you see is 21 points. That's a lot. There are other treatments that have large gains but don't have as many subjects, and there are other treatments that have small gains but have large subjects. Now let's go back to the schema that I presented before. We know that we can understand what the effect of the brain damage is on the brain itself, and we know that that results in a language manifestation such as stroke and aphasia, and the person has trouble with reading, speaking, and writing. We also know that when we test these patients, we get specific scores of what they can and cannot do. So if we were now to add this information about treatment gains into the picture, we can then say, for this individual who has trouble with understanding what's being said to him or following auditory commands, if he were to do treatment, the average gain that you could expect for this person is 23 points. And this is data from 205 other people who look just like him who've done this therapy task. Now let's go back to John, because I brought him up at the beginning. And let's assume that his stroke has affected a certain part of the brain, and we know what the effect of the stroke is on his language function, and we have a set of scores for him in terms of what he's able to do and he cannot do. And let's pick rhyme judgment, because that's one of the tasks that he has a hard time with. He's at 50% accuracy. And now we're able to say, for John, who's 48 years old, who's had aphasia, who's between 40 and 80% accuracy, what is the population, the closest cohort that can tell us how much gains John can expect in terms of the therapy that he's going to get for rhyming. Remember, he's starting at 50%. And we have data now that says, oh, you can expect a gain of 30 points if somebody like John does this therapy task. So now we're able to use this population analysis, bring it back into this equation that I said was the missing piece, and then develop better predictive models, better treatment outcomes for individual patients once we know where their level of deficit is. And taking this even forward, we can actually be able to make prescriptions even before the patients start. So in the case of John, we can say that based on the profile he provided and based on the predictions that we're able to compute, he probably needs a year of therapy working on 15 sessions of reading and 10 sessions of short-term memory and then another 25 sessions, and he's probably ready to go back and return to community activities. And that may be very different from the prescription that Mary gets, who is a 70-year-old woman who's admitted to the hospital, and based on her profile and her language impairment and deficit, she may require much longer therapy. So she's going to have a much longer trajectory of recovery, and we will be able to provide her with the right kinds of therapy prescriptions before she even starts the therapy. Now, as I said, this is in the future, but we're not that far away. And it's an exciting time to be trying to change the way we deliver better care to our patients. Thank you very much for your attention.